Ventilation perfusion mismatch, or VQ mismatch, is the most conceptually difficult cause of hypoxemia to understand. The key notion to grasp about it is that VQ mismatch can occur when the total ventilation and total perfusion to the lungs is completely normal, but when the ventilation and perfusion are not matched up appropriately in different areas of the lung. So as a simple example, let's say you have 5 liters per minute of cardiac output and 5 liters per minute of ventilation of the lungs, and these are relatively normal numbers. If 2.5 liters per minute of the blood goes to the right lung and 2.5 to the left, and 2.5 liters per minute of gas goes to the right lung and 2.5 to the left, then that's great. It's matched up appropriately. There's no VQ mismatch. But if, as a very extreme example, 4 liters per minute of blood goes to the right and 1 liter per minute to the left, while only 1 liter per minute of gas goes to the right and 4 liters per minute goes to the left, then there's going to be VQ mismatch. Why? How is this going to affect gas exchange? Ultimately, it's because the oxygen-hemoglobin dissociation curve becomes flatter at higher levels of arterial partial pressure of oxygen. Now, what does this have to do with it? Well, let's say in this situation up here, where there's no VQ mismatch, let's say you're operating around here on the curve, around 100 millimeters of mercury. But then let's look at what happens in VQ mismatch. The right lung has a lot of blood, but not much ventilation. So the oxygen content in the blood leaving that area is going to be quite low. And the oxygen saturation might be only 50%, much less than the normal situation above. But what about the left lung? The PO2 in the blood leaving that region is going to be very high because there's so much more ventilation than perfusion to that lung. So perhaps that left lung is operating way out here around 150 millimeters of mercury. But look, that's hardly any more hemoglobin saturation or oxygen carried than in the healthy lungs above. So what you see is the blood from the poorly ventilated lung is carrying much less oxygen than normal, while the blood from the well-ventilated lung is not carrying much more oxygen than normal. So the final result, when you mix all this blood coming from both lungs back together, is hypoxemia. So to put all that into one sentence, the idea is the well-ventilated regions can't compensate for the poorly ventilated regions because of this sigmoidal curve. So that's the mechanism. And now, of course, VQ mismatch doesn't just have to happen between entire lungs, the way we did in this toy example. It much more commonly occurs between different regions of the lungs. But from this example, we can see why VQ mismatch responds to supplemental oxygen. Because up here, for example, if we increase the oxygen going to this lung as well as the other, we're going to move up on this curve. And we can also see from this why the AA gradient is going to be increased, because the average alveolar oxygen is quite high in this case. You have a very high oxygen concentration in the gas in this lung, but the blood ends up with a low arterial partial pressure of oxygen. So what diseases cause VQ mismatch? Any disease that alters lung perfusion can do so, and a notable example is pulmonary embolism. And then any disease that alters ventilation to certain parts of the lung can do it as well, and that includes COPD, asthma, atelectasis, which is a very common problem in hospitalized patients. It can occur in the setting of bed confinement when atelectasis occurs in the dependent lung zones, and patients with abdominal pain also might take shallow breaths to avoid worsening discomfort, and that can lead to atelectasis. Pulmonary edema can also alter ventilation, pneumonia, and aspiration. And note that the body is well aware of VQ mismatch and tries to prevent it. And the way it tries to prevent it is by vasoconstricting blood vessels in areas of the lung that are poorly ventilated. That way it decreases Q, where V is low. An interesting result of this is that vasodilators, like calcium channel blockers, can actually worsen hypoxemia by interfering with this mechanism.